Welcome, everybody. My name is Eric Tridas, and I am a developmental and behavioral pediatrician here in the Tampa Bay area. And what I want to do today is just go over general guidelines on how to screen in a primary care setting for autism and related disorders. Just as a form of disclosure, I am a speaker for several pharmaceutical companies. I am also a consultant for them, and I have done research for one pharmaceutical company. The primary reason for us as pediatricians to do screening in a primary care setting is because these are the recommendations of the American Academy of Pediatrics. And in 2006, the Academy suggested that we start looking at developmental surveillance at the regular visits so that we can identify the areas of concern as it pertains to child development. And if we have any questions, we can then do a screening, and then subsequently we can refer if necessary. The recommendations suggest that we do specific screening for autistic-related disorders at 18 and 24 months. And for that, they have provided us with the MCHAT and other tools that will help make those assessments more effective. So, why would we want to screen? Well, Individuals with Disabilities and Education Act, IDEA, was amended in 1997 and 2004, and it mandates that early identification and intervention for developmental disability should be available to all children. So, as the primary care providers of children, we have a responsibility to ensure that these services are given to them. We also know that the earlier we start, the greater the impact we can have in this population. We know that 17% of children present with developmental disabilities, and at least 2% of them will have a severe disability. The population at risk is growing, and the good thing about it is that we can identify those children that are at risk very early on. Children with learning disabilities, or the risk for learning disabilities, can be identified by their language patterns at the age of 3 years. So we really have a responsibility to assess the developmental functioning of our patients every time we see them. There are four main domains that we look at in terms of general disabilities. We look at motor domain, we look at daily living skills domain, communication domain, and socialization domain. And we use motor domains to take care of ourselves, and we use communication domain to socialize. We're going to focus today primarily in the communication and socialization because those are the areas that affect autism. But I also want to talk a little bit about motor development and how we assess it as part of our general surveillance. Gross motor development, as you all know, involves large muscles of the body, and the primary goal of gross motor development is for us to really walk. And we see a very logical and systematic progression of development throughout the first year. And these are milestones that are very easy for us to diagnose. Many of us are very familiar with assessment of motor development, particularly through the training that we had in terms of the neurological assessment of a newborn infant. And those of you who had the opportunity to do rotations in the developmental pediatrics and do neonatal developmental follow-up assessments. In assessing fine motor development, what I have found is that conceptualizing the child's body over the first year of life will be very helpful in helping you as a primary care physician identify when are the times that I should be expecting to see things happening. So if we break the body of the child into 4 parts, and we break the first year of life into 4 quarters, we can have a very easy understanding of what to expect. As this diagram shows, the first 3 months we control head and neck. By 6 months we're working with the upper trunk, the shoulder girdle, and freeing the hands. By 9 months we incorporate the pelvic girdle and the knees, and by 12 months we incorporate the legs and the feet. So if we look at how this leads to a skill, we know that head control occurs by 3 months. The child may hold a sitting position, may reach, may begin to creep by 6 months. and then by 9 months, they're crawling and pulling to stand and beginning to cruise, and by 12 months, they're supposed to be walking. So this will give you some general guidelines in making these evaluations of your patients during the first year of life to know which of the kids are at risk for a gross motor problem. Remember that asymmetry is going to be a concern. Children should have symmetrical development of their extremities. We should not be seeing lateralization or favoring of any particular side in a very noticeable way. So as we assess primitive reflexes, as we assess the postural reactions and the protective reflexes that will develop over the first year, we will see that we should be looking for those to be symmetrical and to be occurring in the projected fashion based on the child development. The reason why we begin to see this progression is due to myelinization and the suppression of the primitive reflexes. Pretty much by 4 months of age, we see a lot of the early primitive reflexes, Moro, ATNR, the asymmetric tonic neck reflex, the symmetric tonic neck reflex beginning to disappear. The grasping reflex is also beginning to disappear. By 6 months of age, that should be all gone because we have voluntary grasping and we should be able to hold the sitting position. In order for us to stand voluntarily, we need to eliminate the supportive reflex, and to walk we'll have to also eliminate those children that present with gross motor delays like cerebral palsy. A lot of times have movement development regulated by their primitive reflexes. So you see a very prominent asymmetric tonic neck reflex, which will then interfere with their capacity to reach and transfer, because the nasal arm, the arm that is going to be and in the direction where the nose is pointing. So if I turn my head this way, this arm will be extended, and in order for me to grab an object with that right hand and bring it to midline to explore, I will have to turn my head, and at that point, my arm would be fisted and coming to the back of my neck, and I cannot have midline exploration. Now, fine motor development is the other motor development that we have, and fine motor development is essential for adaptive self-help skills, because we feed ourselves with our hands, we dress ourselves, and those are critical aspects of independence that we're going to be looking later on. So we're going to look at very precise movements of the fingers. And as a basic principle, these 3 fingers are used for precision. So you grab the pencil this way. If you're a surgeon, you grab the scalpel this way. These 3 fingers are for strength. So you grab the hammer this way. And that's what we want to see happening in the progression of motor development. Fine motor development, I should say. So we want to see how they're going to use their fingers in a precise fashion. So mostly fine motor development involves the use of the hands and how they're going to manipulate objects and precise movements. In terms of progression of fine motor development is also a very predictable pattern of development. It progresses in a proximo-distal fashion. So in the typical anatomical position, we're going to see that the improvement or in precision is going to go from the wrist to the tip of the fingers, and from the radial side, from the thumb, from the ulnar side, from the pinky to the thumb. So that's how we're going to be assessing the fine motor development. Well, as this diagram shows, when we look at the children, when you're assessing fine motor development, everybody has their little wooden 1-inch blocks. When you look at the type of grasp, you'll see that on the top of this diagram, you have the ulnar grasp with the child grabbing the block with the last 2 digits, moving more medially, and ultimately using the opposition of the thumb to grab that block. When we look at the bead, and for all of you who are all pediatricians, in the old Denver, we used to have the racings. When we see the raking motion, kind of like a pincer grasp, we begin to see the incorporation of the thumb and the index finger, and then ultimately we have what is called the overhand neat pincer grasp, which is this way. Typically, kids have that by about 9 months. It coincides with crawling, and that's when you do your anticipatory guidance to make sure that there's no small objects laying around the house, because the kids will be picking up fuzz from the floor, eating the little dead bugs and all of that stuff there. When we look at pencil grasp, again, as the diagram shows, at 1.5 years of age, we have really a true ulnar grasp, which is a true fist with the tip of the crayon coming out of the pinky, moving more to a static type of radial grasp, incorporating the thumb, the index finger, and the middle finger, and then ultimately we may have the fingers extended but not moving independently, and then we have the mature tripod pencil grasp. In writing, the fingers are responsible for vertical movement and circular movement, and the wrist takes care of the horizontal movement. If you have an immature grasp, it's going to bring the object towards the pinky. So you're going to see the children immobilizing the fingers and sometimes even wrapping their thumb to immobilize them, and then they're going to use gross motor function to write. And a lot of that has to do with proprioceptive function, because gross motor function is going to give you a larger proprioceptive input than the small fine motor function. When you are prescribing occupational therapy to facilitate fine motor function, it is essential that there's a lot of practice involved with these skills. While it's critical to have truncal stability and shoulder stability, what is important is the practice for precision. This is no different than what we do when we're playing sports. If you want to get better at batting, if you want to get better at driving a golf ball, if you want to get better at serving a tennis ball, you got to go and practice and practice and practice. So that is of the utmost importance that we focus on that. Again, the diagram is a simple diagram that demonstrates the progression, the cephalocaudal progression of gross motor development, with progression on a proximal distal fashion of fine motor development. Another important thing to look at movement patterns is that they progress in a very predictable way. Gross and fine motor skills progress first in an anteroposterior plane. They then move to a lateral plane, and ultimately we add rotational movements. So when you watch a baby walking, when they start walking, they usually start with a wide base and a high guard, because that protective reflex is going to be there for the forward parachute, and they move forwards and backwards. They sort of follow their head whichever way they go, and then they begin to incorporate some lateral movements, and ultimately they narrow that base, so they bring their feet together because they have much more postural stability. The hands go down and they add rotational movements. The same thing happens when they crawl. The same thing happens when they are drawing. If you look at the first drawings of the developmental test of visual motor integration, you have a vertical line, a horizontal line, and a circle. So that's primarily how all movement progresses. Children that have abnormal motor patterns tend to move in an anteroposterior plane. The classical child that may have truncal instability, either due to spasticity or other problems, tend to sit in what we call a W sitting position, where they rotate their legs inward and extend the feet out, and that gives them a broader base. So when they come from crawling into sitting, they don't pivot and rotate, they actually come up straight, and they have minimal rotational movements in that position. Now let's move into language, and I think that is important to separate the components between speech and language, and that is critical, because a lot of times when we prescribe speech-language therapy, or when the kids are going to school and they're getting speech therapy, the parents don't understand the difference between the two of them. Speech is the mechanical aspect of talking. All that we're doing is making noises, and what we're doing is exhaling and coordinating the vocal cords with our tongue, our palate, our teeth, our cheeks, our lips, and that's how we make noises. That's how we make sounds. And we combine those sounds to make words. Speech therapists can be very, very good at managing that. Language deals with content. And we have multiple components of language. The most basic unit of every language is sounds. So when they are in school, that is going to be critical for spelling. But we look at roots of words, prefixes, suffixes. And when we're looking at language development, for example, many of us listen to little kids talk and they see the pattern. So they know that if I'm dealing with a verb and it's in the past, I can put ed at the end of it. But there's irregular verbs. But the kids that understand the patterns may say things like I ran it as opposed to I ran. And that tells you that they're understanding how these words are put together. They are understanding the morphology. Syntax is the capacity to put words together into a sequence that will make a sentence. So it has to be logical. Discourse is the ability to put sentences together into a complete thought. So when you're stringing sentences together, that's discourse. Semantics, the meaning of the word, your vocab. If you don't know the meaning of the word, you cannot communicate effectively. And pragmatic language skills, which we're going to talk about a little bit later on, which have to deal with your ability to be reciprocal in your communication, to basically understand what the person means by what they say, to understand that the listener is not thinking what you're thinking. And those are key factors that we're going to be assessing in language development in children that present at risk for autistic spectrum disorders. All of these functions will be based on the context of culture and the individual communities, and that is called metalinguistic skills. So this is going to be very important, and probably of all of the developmental skills that we assess, the most important one is language. Again, we talked about articulation, voice, and fluency as being the most important aspects of speech. Speech progression also happens in a very logical way, and it happens from the center of the body to the outside. So little babies begin to produce open vowel sounds and soft sounds, so they have ahs and ha and that type of noise. They move to the guttural sounds afterwards, cooing. So when you are assessing a 3-month-old baby and you're asking, is your baby cooing? They're coo and ga, and that soft palate and the back of the tongue. And then we move to the front of the tongue and the hard palate. So we have the t and the d. So that's why they say dada before mama, because mama is a bilabial sound and it's coming out. And then they do papa. So in other cultures, when instead of calling them daddy, they call them papa, they say papa after mama. And that helps the kid, you know. So anyway, what do I look for in my history? If you cannot swallow, and that's a reflex, if you have trouble feeding early on, if you cannot latch on when you're nursing or to the bottle, that is a kid that you're going to watch very closely for language development, because it tells you that the coordination of the oral motor musculature is not appropriate. And if it's not appropriate, you're going to have difficulties with speech. It's very likely that that will happen. Another group that you want to watch is kids that have problems with fine motor function tend to have problems with articulation. And it has to do with the concept of athetosis. If you think of athetoid movements, they tend to be distal, so they're occurring in the tip of the fingers, slow writhing movements, the worm-like movements that the book describes, and in the orofacial musculature. So we see an association with movement control of the orofacial musculature and the fingers. So if you have fine motor problems, make sure that you monitor speech. If you have a severe articulation disorder, make sure that you monitor fine motor development. Those are the things that over time will be critical, because when you think about what the children have to do in school in terms of writing, it will be essential for you to assess those fine motor skills early on. So that's part of what we look for. Now, I had a good friend who went to one of my lectures in learning, and he said, I really liked what you said, but I will never remember all of the things that you talk about. As a primary care physician, what I need to know is, when must I refer a patient for an evaluation? And what I told him was, well, if you ever have a concern about language, you must refer that patient. And he said, well, how much of a concern should I have? And a basic rule of thumb is that a child that is a year of age should have at least one word in their vocabulary besides mama and dada. A kid that is 2 years of age should have 2 word phrases and a minimum of 200 words in their vocabulary. And a kid that is 3 years old should have 3 word phrases minimum and a minimum of 300 words in their vocabulary. If they don't, they are in deep trouble. So if you don't get that from your history, make sure that that child gets a referral. We need to evaluate that child. Language development is the most significant aspect of development as it pertains to cognitive function. Do not assume that because he's a boy, he's going to talk slower, or that everybody's talking for the kid. Err on the side of caution. Never, ever, ever mess around with a child that has a developmental language delay. Please be aggressive. You can make a world of a difference in this child's life by intervening early. Do not wait. It's not worth it for this kid. So, let's go to autism spectrum disorders. As you know, the prevalence of autism has increased dramatically, and there's many theories as to why this is happening. But the reality of it is that there has been a significant public awareness campaign related to autistic spectrum disorders. We have improved our diagnostic techniques and our recognition, and I believe that there's probably an increase in the incidence in and of itself. So it's important for us to begin to recognize this population. And as I mentioned before, the language skills are going to be critical to the assessment of this population. We know that about 30 to 40% of parents volunteer concerns without prompting about their kids. Okay, this is very, very significant because we're having a large percentage of the kids that are having developmental problems that the parents are not reporting that concern. Clinical judgment, just on that brief visit that we have with the child, is not going to be sufficient to assess it. You know, if we look, for example, at the diagnosis of ADHD, 85% of your patients with ADHD are not going to show the symptoms in your office. So you have to make take the proper history in order to make the diagnosis. So the same thing has to happen here. We are also trained on looking at certain developmental milestones and certain developmental disorders more than others. You know, a lot of us have had training, for example, in motor disorders, so we can diagnose CP fairly easily. But a language disability may be a little bit more subtle and more difficult for us to diagnose because in our training we may not have gotten enough experience in that area. About 1/3 of the parents of children with an autistic spectrum disorder recognized that there was a problem before their child's first birthday. And 80% of them saw problems by 24 months. So that's why it's so important that we do these assessments at 18 and 24 months, because these are critical years for us to really recognize who are the children that are at risk. We may not be able to make a definitive diagnosis, but we can assess whether the language is delayed. We can assess whether this child has other problems that must be intervened in. So that's what we're looking for. Even though the parents recognize that the kid is having problems so early, the diagnosis is usually not made until about 3.5 years of age. And if you are a child in a minority group, it may be as long as 5.5 years of age. So what happens is those kids are getting to school, and then a diagnosis is made, and we have missed critical years of intervention that they could have received to minimize the problems that they're experiencing. Early intervention makes a significant difference. Studies out of the University of Washington show that when we look at ultimate development in terms of cognitive development, IQ, we can see a difference of up to 18 points in those children that receive early intervention versus those that do not. They only got about a 4-point increase. Receptive language scores increase significantly, as well as socialization skills. Again, if your communication, and communication is verbal and nonverbal, if your communication abilities improve, you will be able to socialize much better. In terms of outcomes at the age of 3 years for siblings of children with an autistic spectrum disorder, again, looking at who are those people that I need to watch closely. Well, 61% of them are unaffected. That means that we're left with 39% of siblings, of individuals, of children that have been diagnosed with autism that are at a very high risk for a developmental disorder. 19% of those kids already at the age of 3 have a diagnosis of autism. So the incidence in families is very, very high. And we also need to look at those that have cognitive impairment, because we have a higher symptoms severity and lower cognitive scores in 20% of these kids.